patient safety goals. Okay, I'm going to discuss about the international patient safety goal. First goal is identify patient correctly. Second goal is improve effective communication. Third one is improve the safety of high alert medication, and fourth one is ensure correct site, correct procedure, correct patient surgery. Okay, the fifth one is reduce the risk of healthcare associated infection, and the sixth one is reduce the risk of patient harm resulting from falls. Okay, so we will discuss one by one. First one is the identify the patient correctly. So why we want to identify the patient correctly? The correct patient, we can give the correct care. Okay, so here in our hospital we are using the identifiers, that is we are using two patient identifiers. First one is the full name of the patient, and second one is the medical record number. Okay, so this is mainly for the adult patient. In our hospital, the most of the patients are coming with the same type names like Muhammad Ahmad, Muhammad Ahmad. Okay, so all these patients are having the same phonic name. So not only we are going on with the full name, but also we want to confirm with the medical record number. Okay, so this is for the adult patient. So what regarding the newborns? In our hospital for newborns, we are concentrating on two ID bands, one on the wrist and one on the ankle. Okay, in the wrist, the baby's information, that's a newborn baby's information, baby girl of Nasriya, like that's the example, and the medical record number. And in the ankle, we will apply the mother's ID band. Okay, for the not misunderstanding. Okay, so here we want to secure it for the newborn babies. The ID bands must be very much secured and it must be properly maintained. Okay, so not only during the time of admission and emergency department, so we also want to identify the patient before, which are all the situation. Okay, so in the daily basis we are giving medications, we want to do identification each and every time of the medication administration, and giving blood and blood products, and also taking blood samples or any specimens samples for clinical testing, and before providing treatment and procedures. So not only in the time of admission, ongoing care also, before giving medications, before administration of blood and blood products, before taking blood or any other specimen for clinical setting, and before providing treatment and procedure, we must identify the patient to ensure that this is the correct patient and we are giving the correct care. Okay, and the second international patient safety goal is improve effective communication. Okay, so improve effective communication. What is effective communication? Here we can tell it is a effective communication if it is timely, accurate, complete and understood. Okay, so these all the criteria want to be there to make a communication effective. Okay, so the communication may be of different type. It may be electronic, it may be telephone communication, it may be verbal communication, or it may be written. Okay, so in this four type of communication, we can tell the safe zone or has less error in electronic and written communication, but comparing the other telephone and verbal orders are having more error prone communication. Okay, so now we will discuss what are the rules we want to follow while doing or while carrying out the telephone order and verbal orders. Okay, so first of all, the telephone orders. The telephone orders, first of all, the receiver should receive the information and write down the entire order. Okay, so write down the entire order clearly. So when writing, it should be readable and has a good handwriting. Okay, so and also second thing, after writing down, we want to read back the order for verification purpose. Okay, and the third thing is we want to witness with a staff nurse. Okay, so we have the co-workers or the colleagues. So another registered nurse must be there for the witnessing purpose, both witnessing and they want to sign in the written documents. Okay, so both the registered nurse must sign in the telephone order. Okay, and the last thing is not only writing and signing by the nursing staff, it should be signed by the ordering physician within 24 hours of the ordering time. Okay, so these are the rules we follow in the telephone order. And the second one is verbal order. Okay, so the verbal order, first, as a nurse or the nursing profession, we want to listen the order carefully first of all. Okay, and second thing is start the order, don't delay, because this verbal order will be done in time of emergency situation or code blue. Okay, so here the starting time is very much important. We want to start the order at the time we receive the order. And also, after finishing the procedure or the medications, the order must be signed by the ordering physician as the situation over or before the physician leave from the area or our unit or department. Okay, so these are regarding the verbal orders. So what are the things we want to do? First, listen carefully, repeat back, and start the order immediately, and sign after the situation over or before the physician leave the area. Okay, and the verbal order is only accepted by the emergency situation, by also the treating physician only. Okay, we can accept from the treating physician only. Okay, and some of the points you want to keep it in your mind, that verbal order should not be received in all these types of medications. Okay, so I will list out the medications where the verbal orders are not accepted. Okay, so first one is the cytotoxic agents. So you all know it is a chemotherapeutic drug agents. And second one is the concentrated electrolytes like potassium chlorate, potassium phosphate. So these are the concentrated electrolytes. So third one is sedatives and narcotics. Example of sedatives, phenobarbital and diazepam, and the example of narcotics, morphine, codeine, like this. Okay, this also not accepted as a verbal order. And immunotherapy, mainly used in cancer treatment. And investigational drugs like experimental drugs, so we can tell this as antipsychotic agents like. So these are the areas where the verbal orders are not accepted. And the one more thing you want to keep it in your mind, the routine order should not be accepted. So in the next is the critical resulting point. Okay, so critical resulting point, from the laboratory it should be reported 15 minutes. Okay, so within 15 minutes the critical result reporting will be there, and from the radiology within 60 minutes. Okay, and next we will move to ISBAR communication. So in the effective communication we are dealing with the telephone order, verbal order, critical result reporting, and ISBAR. Okay, so we will move to ISBAR communication. When ISBAR communication is done, so mainly used during the transfer of patient from one department to the other department. Here you can able to see the ISBAR tool. I means identify, S means situation, B means background, and A means assessment, R requirement. Okay, so the identify, both identify the patient as well as the staff. Okay, so yourself means the staff, the name of the staff, position, location, and also the patient name, age, sex, and location. And situation, what purpose, for what purpose we are sending the patient from one department to another department. Maybe it may be for investigation, it may be for consultation or procedure. So it may be many reason, and you want to be surely clearly tell the reason I am calling and why, what purpose the patient is shifted from one department to another department, and whether it is an urgent based or it need the emergency lookup. Okay, so all this thing we want to deal with the situation. And in the background, tell about the patient, tell the history, what's the diagnosis, what's the present compliance, what are the examination test results, normal and abnormal results. Okay, or any current management, or any abnormal vital, unstable vital signs, everything you want to deal with the background. And assessment, so you want to go with ABCD approach: airway, breathing, circulation, disability, exposure. So you can tell whether the patient is on oxygen flow, and you want to maintain the particular position like a sideline position, or any other related positions or the expected positions. And in the requirements, so be clear regarding the requirement, and state your request and urgent review. Some in emergency situation the time framework is very much important, and also the approval recommendation, everything just go through and make a opinion for appropriate management. So in the ISBAR tool, identify situation, background, assessment, and requirement. The third thing is improve the safety of high alert medication. Okay, so here high alert medication, you can able to see in the slide a red label, high alert double check. Okay, so high alert medications always must be double checked, and it should have the label. Okay, so and second thing I am discussing about the LASA drug also, look alike and sound alike medications, and also the concentrated electrolytes. So we can discuss about the top 5 high alert medications. First one is the insulin, second narcotics, injectable potassium chloride or phosphate, IV anticoagulants, sodium chloride solution above 0.9 percentage. Okay, so these are coming under top 5 high alert medications. So first thing is we will discuss regarding the narcotics. Okay, it is an important medications in narcotics. Narcotics always should be in the locked cupboard. Two keys must be there, and it is handled by two person. One key by the team leader and the other key by the nursing in charge. Okay, and it should be always in the double locker. And each shift the inventory must be checked. Okay, how much the drug is there and how much it is used, and what's the remaining medication available in the locked cupboard. Okay, so in each shift of the nursing care, we want to check the inventory of narcotics. And regarding the narcotics, after using the narcotic medication, the extra medicine, so sometimes the doctor will order for 100 mg pethidine, we are using only 75 mg. Okay, so the remaining ampule dosage, what we want to do. So okay, we can't able to as usual medication don't deal with the narcotics, just it may be misused. Okay, so what we want to do, we want to discard in running water. The remaining dosage of the medicine we want discard in running water with a registered nurse witness. Okay, so the two person will be there during the time of top 5 high alert medication. I'm talking regarding insulin, narcotics, injectable potassium chloride and phosphate, IV anticoagulants, and sodium chloride solution above 0.9 percentage. And narcotics, I make it confirmation that extra medicine must be misused, may be misused, and we want to discard in running water with a registered nurse witness. And the empty ampules replace to the pharmacy immediately. Okay, and the injectable potassium chloride and phosphate, it should also be just keep it in a locked cupboard. And intravenous anticoagulants, example heparin. Okay, so heparin like medicines also we want to keep it in a safe locker. And sodium chloride solution above 0.9 percentage. Here, what's the difference? Sodium chloride solution above 0.9 percentage and the normal 0.9 percentage sodium chloride. So if you are, instead of using the sodium chloride solution above 0.9 percentage, that is hypertonic, for sodium chloride solution 0.9 percentage, what happened, there is a chance of death and hypernatremia will be happening. So be careful when dealing with this percentage of sodium chloride. It should not be above 0.9 percentage if it is required. Okay, and the next, these are the narcotic checklist. Okay, so the medication count sheet I told, in each inventory we want to check with the medication inventory. First, the staff signature must be there, date, time, the quantity in hand, and the quantity as administered, and the quantity remaining. Okay, so these are the narcotic checklist. In each and every shift of nurse, they want to check the inventory. Then we will deal with look alike and sound alike medication. Okay, so the medication names that sound similar are identified as sound alike medication, and medication names in which packaging is visually similar to another medication are identified as look-alike medications. Okay, so some of the example of this look-alike medications are ampicillin, amoxicillin, metronidazole tablets, and metformin hydrochloride tablets. So it is looking like same, so there may be a confusion, and as a nurse we want to be very careful while dealing this type of look-alike medications. Okay, then we will move to the sound-alike medication. So these are the sound-alike medications. We can able to pronounce it as a same like, but it is a different action. So we want to be careful. Amlodipine, amitriptyline, atenolol, allopurinol, carbamazepine, carbimazole, propranolol, prednisolone, rivaroxaban, and rosuvastatin. Okay. So these are like sound alike medication. So this look alike and sound alike medications also want to be stored in separate cupboard with the proper label for the misinterpretation and mistreatment. Okay. So the fourth international patient safety goal is ensure correct site, correct procedure, correct patient surgery. Okay. So here during the surgery, so the it's a patient is planned for a surgery, we want to be concentrate on the correct patient, correct site, correct procedure, and the correct site. Okay, so we call this policy as a time out policy also. So these all point must be keep it in your mind before we are starting the procedure of surgery, that is ensure correct site, ensure correct procedure, and also the correct patient surgery. And regarding the site marking, okay, surgical site marking, here the site marking must be done by the physician or by the procedure, the physician who is doing the procedure. Okay, the mark is unambiguous and is used consistently throughout the organization. It should be clear, the mark should be very clear, and the mark is made at or near the procedure site, and the mark is sufficiently permanent to be visible after skin preparation and draping. Okay, so after doing the sterile draping or this making sterile field, this marking should be sufficiently permanent for the correct procedure, and there is no doubtful in the procedure site. Okay, these are regarding the surgical site marking. Then we will move to the surgical safe checklist. Okay, so we can able to see the surgical safe checklist here. Before induction of anesthesia and before skin incision, before patient leaves operating room. So we will make it as a order wise as sign in, time out, and sign out. Okay, so what you are doing in sign in and time out and sign out. So, okay, so to make the correct patient, correct site, and correct surgery. Okay, to make the patient safety. In first sign in, the patient must be identified, the site must be identified, the correct procedure, and we want to look for the consent is signed by the patient. Okay, and the site is marked. Already I showed the site marking must be permanent, and the anesthesia safety checklist is completed. The pulse oximeter or the vital machines is on flow, and it is in the stable. And if does the patient have any known case of allergic reaction and any difficulty in airway or aspiration risk, or any risk of blood loss, the blood loss is more than 500 ml. Okay, so all this want to be make sure in sign in. And in time out, in the time out, like just introduction of the team by the team members, the name and the role. So all the team members name and role must be introduced clearly, and confirm the patient, site, and the procedure. Correct patient, correct site, and correct procedure. Okay, and want to discuss regarding the anticipated critical events. Anything happened during the time of surgery, the team members must be aware of that. Okay, and regarding the antibiotic prophylaxis, whether with last 60 minutes the patient taken the antibiotic within the last 60 minutes, it should be confirmed, and whether any essential imaging is displaced in case of needed. Okay, so these are in the timeout. And after, before patient leaves operating room, sign out. In the sign out, nurse verbally confirms with the team. Okay, so the name of procedure recorded, instruments, sponge, needles counts are correct, how the specimen is labeled, any equipment problem to be addressed, and concern for recovery and management of the patient. Okay, so what are the management it want to be given in the recovery period, it should be discussed. Okay, so these are the surgical safety checklist that should be followed for identifying the ensure correct site, correct procedure, and correct patient surgery. And next we are moving to the international patient safety goal. 5, reduce the risk of healthcare associated infections. Okay, so mainly we are concentrating on hand hygiene. You all know the type of hand hygiene. The hand rub 20 to 30 seconds, medical hand wash 40 to 60 seconds. So the IPSG 5, reduce the risk of healthcare associated infection, hand hygiene, hand rub 20 to 30 second, medical hand wash 40 to 60 second, surgical hand wash 3 to 5 minutes. Okay, so this thing must be followed to reduce the risk of healthcare associated infection. Mainly we call it as nosocomial infection. Okay, so this is a familiar topic. I'm just showing you the slide. These are the steps of how to hand rub, okay, to make the hand hygiene. The duration of the entire procedure is 20 to 30 seconds. And medical hand washing. So you know the steps, which are all the steps is involved. And also the time period want to be concentrated. And surgical hand washing. The movements and the steps of surgical hand washing. So the hand hygiene is important. I am explain detailedly regarding the 5 hand hygiene movements. Okay, 5 movements of hand hygiene. So this is very much important. First, we want to concentrate. We want to make hand hygiene before touching a patient, and before clean aseptic procedure, after body fluid exposure risk or after the procedure, and fourth one is after touching a patient, fifth one after touching patient surroundings. Okay, so these are the 5 moments of hand washing. You want to keep it in your mind to make the hand hygiene properly and preventing the nosocomial infection. Before touching the patient, before the procedure, after the procedure, after touching the patient, and also after touching the patient surroundings. So next international patient safety goal is reduce the risk of patient harm resulting from falls. Okay, so all admitted patients are assessed as to their risk of falling on admission, transfer, following a change in condition, and post fall using a approved modified Morse fall risk assessment tool. Okay, so the during the time of admission, during the time of transfer from one department to another, any change in condition from the normal thing, and any incident of fall. Okay, after the fall also we want to check whether the reason of fall and how we can able to modify the fall risk. Okay, so this done by the Morse fall risk assessment tool. And this is a Morse fall risk scale. The history of falling immediate or within 3 months, and the scoring, if there is no history, 0, and there is a history, the score is 25. Secondary diagnosis, its present means 15. Ambulatory aid and bed rest, nurse assist, crutches, cane, walker. So the according to the usage, the score is there. And IV, heparin lock, gait transferring, normal, bed rest, immobile, weak, impaired, and in the mental status, oriented to own ability or forget limitations. Okay, so these are the criteria of Morse fall risk scale, and the scoring is 0 to 24 no risk, 25 to 50 moderate risk, and above 50 the high risk. Okay, so according to the scoring, we want to deal the patient and make a careful assessment throughout the shift. So beyond the time of admission, transfer, change in condition, and post fall, each shift in the nursing, each shift of care, the patient, so hourly nurse, how we can able to reduce the fall risk of a patient. Okay, so the fall risk of a patient can be reduced by using hourly rounds. Okay, so doing hourly rounds, and also orientation of the patient. So immediately after admission, we want to give the patient orientation. Okay, so the orientation regarding room orientation, and also the equipment, how it is placed. Okay, so they want to be clear regarding what is available inside the room. Okay, so the patient safety answer, it's a purposeful rounding. Okay, so in the patient safety answer, we make it as a purposeful rounding the bed in low position all the times. For avoiding fall, the bed in low position at all the times, and the call bell must be very reachable for the patient, and always use the side rails, okay, for the patient to prevent fall, and proper room lighting must be there, and if possible bed alarm technology if patient is high risk for falls, okay, and the personal items within reach at all times. So all these things we want to follow to make the patient safety and prevent fall, okay. Purposeful rounding, that is hourly rounding, we want to meet the patient. Bed in low position, the call bell must be near to the patient, always make the side rails up, and proper room lighting, bed alarm technology must be there, and personal items within reach at all times. And in the hourly rounds, what are the things we want to concentrate in hourly rounds? Okay, what did we do in hourly round? So here we follow the 5 P's. Okay, the 5 P's will be addressed on each round. First P is pain. Okay, so when we are meeting the patient in each hours, we want to check with the pain level, and plus if there is pain, we want to go for pain management also. Second thing is the potty, offer toileting assistant. Okay, so if there is no attenders or no assisting person, we want to offer toileting assistant for the patient, and empty the urinals. Okay, so everything we want to make the patient comfort, because for frequently they are using the toileting, means there's a chance of fall for the geriatric patients, okay. And position, assess comfort position. For each rounds we want to make ask the patient if they are in comfort position, or if any position is acceptable or ordered, we want to make the patient in the correct position. And personal equipments like call light, telephone, TV, remote control, water, food, then empty urinal, tissue box, what are things need for the patient, we want to give near to the patient, easy reachable, okay. All these things want to be keep near to the patient. And last piece, promise to return back. We want to inform the patient if there is no attenders or the patient is alone. So usually we will ask the patient or the attendant, one must be there to take care of the patient. And if there is no, also we want to inform the patient, or promise, we want to give an assurance that we are here to take care of you, and we will make a hourly round of you again. So they will be comfort, and they will be in safer zone, okay. So these are the 5 P's we want to address in each round of our nursing rounds. So at last, I want to discuss regarding why we are concentrating on this IPGS. Okay, so international patient safety goals, mainly in starting itself, I told tens of millions of patients are having this disabilities of injury and death due to the unsafe medical practice. So if you are following in the hospital or on the patient side, this 6 international patient safety goals, again I will repeat: identify patient correctly, improve effective communication, improve the safety of high alert medication, ensure safe surgery, reduce the risk of healthcare associated infection, and reduce the risk of patient harm resulting from falls. If you are following all this, we can able to avoid the sentinel events in the hospital. So what is sentinel events? It may be due to the unsafe medical practice, the patient may prone to face the death, paralysis following surgery, death, paralysis of mother, infant undergoing delivery, retained surgical instrument materials, surgery on wrong body part, wrong patient, patient fall resulting in death, paralysis, serious adverse drug reactions involving the misused drugs, and the last one is major blood transfusion reactions. Okay, all these are sentinel events, and these events may be avoided in the hospital, and we make the patient in safer zone if we are following these 6 goals, that is international patient safety goals. We join together. Okay, so we all join together our hands to make the patient safe, and it's a partnership for us. So we want to give correct patient correct care and giving safety to patient. These are regarding the international patient safety goals. Thank you.